No, thanks a lot. My first problem is I have to speak in English and to speak slowly. Okay, that's the reason why I need a script to make it slowly. Anyway, as healthcare professionals, we have become highly competent in diagnosing things and treating diseases. But we were often less prepared to address suffering, especially existential and spiritual suffering. And yet for many patients, illness is not a medical diagnosis, it's an existential disruption. Therefore, I would like to share with you why spiritual existential needs matter in healthcare, why they often remain invisible and thus unmet, and how interprofessional education will help us to respond more adequately to human suffering. Makes a nice sound. The World Health Organization states that healthcare is not limited to curing disease. Healthcare also carries the responsibility to relieve suffering. And this responsibility includes spiritual suffering. This understanding contributes to the development of spiritual care, as we've heard before. This does not mean promote religion. It means to taking the existential dimension of illness seriously. Questions such as, why does it happen to me, or what still gives meaning to my life, are still there and emerge in every critical situation, even childbirth. And yet many healthcare professionals feel unprepared to give an answer, to respond and address these issues. Not because they lack compassion, no, because they lack time, maybe structures, training, and sometimes clear responsibility. Who should do the job? The chaplains, the nurses, or the psychologists, or whoever. Therefore, it's important to acknowledge that we do not always have to give answers. Meaningful answers can only emerge from the patient's own perspective, own life, own values, and lived experiences. So, if these needs of the patient are relevant, why do they remain so invisible in daily routine? One of the central problems is that patients rarely address these issues. Just a moment. Yeah. They don't talk about it. Usually, in most cases, they don't even know that they could talk about these issues. And as a result, many existential spiritual needs remain unnoticed because healthcare professionals rarely ask. And thus, these needs are unmet. And this is why, at least from my perspective, assessment, structured assessment is important, because what remains invisible cannot become part of professional care. Spiritual care, therefore, requires three things. First, awareness of patients' existential and spiritual needs. Second, a caring and attentive professional attitude. And third, the ability of interprofessional teams to respond together. But do patients actually want healthcare professionals to address these issues? Qualitative findings from Eckhard Frick clearly suggest that many patients, at least from Bavaria, would appreciate physicians showing interest in their spiritual orientation. Of course, this does not apply to every patient, but importantly, many do welcome such conversations. In our outpatients with chronic pain diseases, they prefer speaking with a physician about these issues, rather than exclusively with pastoral workers and chaplains. At the same time, many physicians still feel that it's beyond their responsibility. And pastoral caregivers, of course, emphasize the importance of their own professional role. So we encounter a central paradox. Patients hope for support, while professional responsibility remains diffuse. And when responsibility is diffuse, important needs remain unaddressed. So several studies have explored why healthcare professionals often hesitate to address these issues. Across different countries and professions, the findings are remarkably constant. The most frequently reported barriers are lack of time, we heard about it, insufficient knowledge, uncertainty about responsibility, and personal unease with this topic. Among German healthcare professionals, approximately 40% reported not having sufficient time to address these spiritual concerns. And a similar proportion wished that they had more time for such conversations. Wonderful. In highly pressured healthcare environments, existential concerns may gradually become invisible within the routine care because of these reasons. And this brings us back to the problem: if these needs are not recognized, they cannot be addressed. So this is why assessment is important. One of the core assumptions is very simple: what is not assessed remains invisible. For this reason, we developed structured instruments: the spiritual needs questionnaire, the spiritual needs screener with 10 items, or spiritual distress screener. Very important, it's an opportunity to talk about these issues. It's not a measure just because something could be measured. But patients decide by themselves whether to respond to this issue and turn back the questionnaire to the nurse, for example. This indicates, I would like to talk about it. When they throw it away, they're not open to it. Very easy, very simple. So both instruments are freely available. Importantly, again, assessment is not an end in itself. The goal is responsiveness, an ability to talk about these issues. Even non-religious people can click all these issues and say, yes, it's important for me, no, it's not important for me. And it's very important that even pastoral workers can see there are unmet needs. It's documented. So assessment helps teams to recognize where support is needed, which concerns remain unspoken, and where patients may require existential and spiritual support. And this comes to the next question: what kind of spiritual needs do patients actually report? Across many studies, 4 dimensions repeatedly emerge: religious needs, existential needs, inner peace needs, and generativity needs. In more collectivistic societies, these familiar support needs are very important, while they are less important in individualistic societies. Together, these dimensions reflect different ways in which people seek meaning, connection, peace, and orientation to face life in all its complexity. Importantly, spiritual care should never assume that all patients experience spirituality in the same way. It's important. The relative importance of these needs vary considerably depending on culture, biography, and experience of illness. And these differences become partly visible when we compare different diseases and cultures. So, for example, cancer patients often report stronger needs as compared to those with chronic pain diseases. Chronic pain diseases are the blue barrows on the light side, and the red, Bordeaux red ones are those from cancer patients. You also see that inner peace needs and generativity needs scored much higher as compared to existential needs and religious needs. So no one has to be some fears to talk about religious issues when you're not familiar with it, because patients have other needs. So at the same time, cultural context also shapes how spiritual needs are expressed. For example, patients from Germany or China often report stronger inner peace and generativity needs, whereas explicitly religious needs are more often expressed, for example, in Poland or Iran and Pakistan. We also identified several important predictors of such needs. It's anxiety and depression, illness-related threat perception, spiritual search, or the trust that God is on my side, for example. So these findings suggest that spiritual needs are closely connected with psychological and existential adapting to illness. The same pattern continues across elderly populations, palliative care, early stage diseases, and relatives. So these regional differences, as you can see here, particularly for the religious needs from north to south, parts of Germany and the mid parts, these regional differences found in larger samples may reflect religious traditions, cultural characteristics, family structures, and maybe regional mentalities. I wouldn't come to the issue, why are the northern Germans are so different as compared to south? And it's another complicated thing. This reminds us that spiritual needs are never purely individual. They are also shaped by social and cultural environments. But perhaps the most important question is, do spiritual needs emerge only at the end of life? Our findings suggest a remarkably clear answer: no. Please look on the right side, terminal cancer patients, on the right side, early stage cancer patients. Do you see strong differences? I would say probably not. Patients in the early stage of cancer showed almost the same pattern of spiritual needs as patients receiving palliative care. And in a palliative care, patient would say, we should care about them. Why not for the others in the early stages? Our findings indicate that patients may need such support much earlier in the course of their disease at the time of the diagnosis. Then these problems arise and no one cares for it. Because the others are in the palliative situation, then this topic is of relevance. Yes, healthcare system still tends to focus on spiritual care primarily on palliative care settings. It's important, it's very good that this topic is included in this healthcare system, let's say, to the back door of palliative care. But there are more doors. But existential and spiritual distress often begins much earlier, already, as mentioned, at the time of diagnosis. At precisely that moment when patients are confronted with uncertainty, fear, loss of control, and major disruption of all their life plans. At that stage, healthcare systems primarily communicate diagnosis, treatment options, and prognosis. And many patients are largely left alone with the existential questions that accompany their realities. And this is exactly where spiritual care may become deeply relevant. Not only at the end of life, but from the very beginning of serious illness. This leads to another question: what happens when patients are at home? Let's call it gap of support in the social spatial environment. Most people hope to preserve normality, meaningful relationships, participation, horrible word, and a sense of belonging despite of illness. At the same time, their existential fears and spiritual distress often continue far beyond the clinical setting. And no one cares for it, because we have no structures for it. Again, we see this gap between patients' existential needs and the supportive structures available in everyday healthcare and social care systems. This leads to the next question: who enabled to participate, to belong, and to remain connected when facing illness, vulnerability, or disability? Sorry, sometimes it's gone anyway. At this point, I would like to broaden the perspective beyond palliative care. These issues are equally relevant for people, for example, living with disabilities, where questions of participation, belonging, and inclusion are often linked to spiritual well-being. This insight led to the project I Have Questions, I Want to Participate. Using the Spiritual Needs Questionnaire as a framework, the project explored spiritual needs in relation to different dimensions of social participation. The aim was to identify needs, barriers, and personal resources, and to support dialogue about participation and inclusion. Because spiritual care is also about helping people remain connected, belong, and to participate meaningfully in life. But if spiritual care is truly meant to become part of everyday healthcare practice, good intentions are not enough. Implementation, therefore, requires competencies, structures, assessment tools, at least this is my opinion, and organizational support. Spiritual care competences can be trained. This is very important. And spiritual needs can be systematically and standardized assessed. This insight led to the foundation of the SPECI curriculum. SPECI means Spiritual Existential Care Interprofessional. So this curriculum was developed by an interprofessional professional team, and this expert group later on certified it for the German Society of Palliative Medicine. So it's published, and it's the only curriculum certified. The program was never intended as a basic training for pastoral care. Its purpose was to sensitize healthcare professionals to existential and spiritual issues and all these dimensions of illness and care, and to enable them to respond from their own professional role and perspective. The curriculum combines theoretical foundations, self-reflection, communication training, and practical implementation strategies. It aims to strengthen spiritual care competencies, to improve perception of patients' needs, and to foster interprofessional collaboration. But the key question is, does this kind of training actually make a difference in clinical practice? Just a minute. No, was too far. For this pilot study, the central assumption was straightforward. If healthcare professionals become more competent and confident in what they're doing, this should also influence the care experienced by patients and their relatives. To explore this question, we tested this 40 hours SPECI curriculum across 7 education centers. In total, 91 healthcare professionals participated in the training, unfortunately during the corona pandemic. Anyway, they cared for more than 700 patients and more than 350 relatives. This allowed us not only to examine educational outcomes, but also potential effects on clinical care itself. So which competencies can be actually strengthened to this training? This curriculum focused on the following spiritual care competencies. These include perception, documentation, team spirit, self-awareness, knowledge, conversation, and empowerment. It was assessed by the Spiritual Care Competency Questionnaire developed with Eckhard Frick. Importantly, these competencies are not merely theoretical constructs. It focuses on action, on doing something. They directly influence how healthcare professionals perceive patients' needs, respond to existential concerns, communicate, and accompany patients in everyday clinical practice. Unfortunately, patients entered the training with remarkably high intrinsic motivation and stress. So both. They deeply valued the quality of care, human relationships, and compassionate practice. At the same time, many described a very heavy workload, emotional exhaustion, and the risk of emotional distancing themselves from the patients. We would say it's burnout. No, it's not burnout. It's simply too much. Those experiencing high workload showed lower job and team satisfaction, reduced spiritual well-being, and strong emotional withdrawal from the patients. Would describe it as cool down. It's not burnout. It's an active distancing from the patients. In contrast, participants who felt more satisfied at work responded, had stronger team cohesion, better psychological well-being, and less emotional distancing. So compassion itself appeared largely independent of workload and job satisfaction. This is a good answer. That's a good notion. This suggests that healthcare professionals do not simply lose their compassion because they are under pressure. During the difficult situation of the corona pandemic, the nurses were still there for the patients. Nevertheless, difficult working conditions may limit their ability to express it consistently in everyday care. This became highly relevant for understanding the effects of the training itself. So did the training actually strengthen spiritual care competencies? Yes. Go by yourself to this picture. As you can see, some competencies were very high already at the beginning. For example, perception, conversation skills, and knowledge about other religions. Others have further developed documentation, self-awareness, and proactive empowerment. Unfortunately, team spirit remains low. So this is a challenge. Beyond measurable competencies, participants also reported important changes in their everyday clinical practice. For example, 85% stated that after the training, they responded to patients' spiritual needs much more frequently than before. And an equal large population reported feeling significantly more confident in addressing these needs. This is remarkable because the study took place again under the conditions of the corona pandemic and the restrictions. At a time characterized by uncertainty, emotional burden, isolation, and so on. Participants also reported paying significantly greater attention to appropriate setting for such communications. As we've heard before, we need room, we need time, we need a space for it. And perhaps one of the most revealing findings was, even after completing the course, 87% still wished that they had more time for these conversations. So there's an openness for this topic, but they need time and structures for it. So Education alone is not enough. Compassionate care also requires structural conditions that make human encounters realistically possible. And this leads to the more analytical questions: which factors actually predict whether professionals address spiritual needs more confidently and more frequently? So these are predictor analyses. It looks very simple what is stated here, but again, I hope you trust me, it's published. Our predictor analysis revealed interesting things. First, the strongest predictors of responding more frequently to patients' spiritual needs were self-awareness competencies, team spirit, and job satisfaction. Or in other words, professionals were more likely to address spiritual needs when they reflected more deeply on themselves. What is my spirituality? What are my resources? And when they felt supported within their teams and experienced greater satisfaction with the work environment. Similarly, the strongest predictors of greater confidence in addressing spiritual needs were perception competences and, again, team spirit. These findings suggest that sustainable spiritual care does not depend on individuals alone, but on supportive team cultures. Please remember, what are the teams in the hospital you're working? How they communicate about these issues? Are they really talking about spiritual needs, their own needs, patients' needs? Or as Tove said, it's more or less a no-go. Let's talk about sexuality, not about faith and something like this. And ultimately, of course, the most important perspective is not the professional's perspective. Yes, we're talking about patients. Luckily, we also have some data from the patients. Overall, patients reported very high satisfaction with the support they received during the pandemic conditions. A large majority felt supported not only medically, but also spiritually and existentially. Patients seem to notice very clearly whether professionals are attentive, emotionally present, and willing to engage with existential concerns. And this became even clearer in the predictor analysis. Sorry, I like mathematics, although I hated them during my school time. Anyway, the strongest predictor was not medication or infrastructure. It was support from the medical staff. The next significant predictor was care within palliative care units or hospices. This is interesting because patients in palliative care units and hospices were generally in poorer health, yet they still felt well supported there. It's important to emphasize further that the strongest impact came from the therapeutic and medical staff themselves. At the same time, support from pastoral care providers was also significant predictors of patients' perceived spiritual support. This illustrates that spiritual care should not be delegated away to chaplains, but understood as a shared interprofessional responsibility within the healthcare practice. And importantly, these effects were not limited to patients alone. Relatives are also relevant and appeared of benefit. 85% of the relatives stated that the team had taken good care of the family members' spiritual needs. So it's kind of to objectify the impression of the patients. And about 71 felt support in their own spiritual needs as well. At the first glance, this seems quite nice. Anyway, nearly 1/3 still did not feel well supported. In fact, relatives are often profoundly emotionally overwhelmed by the situation. This raises another important question: what happens when this emotional burden itself becomes spiritual distressing? Although supporting relatives is theoretically widely considered an essential part of palliative care and of nursing competences too, it remains in practical too often optional. We therefore examined spiritual distress among relatives and hospice residents, and the findings were quite striking. Many of them reported sadness, anger, disappointment, and emotional exhaustion. Others questioned the meaning of life at all, just because their relatives are in a hospice. And many expressed a deep need for encouragement, someone who could help find them to strengthen to continue with their life and the situation at all. This spiritual distress was strongly associated with lower psychological well-being, higher perceived burden, lower resilience, particularly reduced ability to tolerate and process difficult emotions. These are clear signs of emotional overwhelm. And they remind us that relatives do not only need information, they also need support and spiritual care. And who's doing the job? Maybe no one. This leads to the next question: can the professional team-based training create even stronger effects? To explore this, we conducted a second intervention study in which entire interprofessional teams were trained together. In total, 21 healthcare professionals participated. They came from 3 different care settings: elderly care, oncology, or disability support. These professionals did not learn separately according to their discipline. Instead, they learned together as teams. Also, in this comparatively small intervention study, spiritual care competencies improved significantly. Compared with the larger studies I've showed you before, involving individuals trained, some effects were even stronger, particularly team spirit, documentation competencies, and self-awareness. This indicates that spiritual care competency do not develop only at the individual level. Again, participants seem to develop most sustainably when they learn together as teams. How are they behaving? How do they respond? So not as isolated experts, but as connected professionals sharing common intentions, a shared language, and mutual responsibility. At the same time, however, these findings also revealed important limits of educational interventions, because training alone cannot compensate for structural workload, staff shortage, or less supportive organizational cultures. And this broadens the implementation perspective. If spiritual care is to become sustainable, not only individuals, but healthcare organizations themselves must change. So the current implementation project, organized by Mareike Gerund, Mareike thank you, is called Take Care Together. The aim is no longer on individual training, the aim is on cultural transformation. The project seeks to stimulate organizational and cultural development through interprofessional training in spiritual and existential care. The broader goal is to develop the development of spiritual culture of care within healthcare organizations. This includes strengthen resilience, improve job satisfaction, fostering professional identification, supportive, sustainable employability among healthcare professionals. In other words, the project asks not only how can individuals provide spiritual care, but how can healthcare institutions themselves become more human environments. And this shifts the perspective considerably from individual competences to organizational culture. Consequently, the project addresses several interconnected levels simultaneously. Cultural development and organizational changes. This includes attitudes and values, communication and team cohesion, and questions of spirituality and care ethics. Employment empowerment. This involves professional development, spiritual care competencies, self-care and resilience, and organizational structures themselves. Because compassionate care also depends on workflows, responsibilities, communication structures, and institutional processes. So the culture of care is not imposed externally. It is developed collaboratively within each institution itself. Because sustainable cultural transformation cannot simply be taught. It must be lived collectively. So encouraging the spiritual specie curriculum has attracted considerably attention in the recent years. Numerous training programs were implemented across different healthcare institutions in Germany, followed by additional structures and so on, and training activities. And perhaps this reflection reflects something very important. Many healthcare professionals, as well as volunteers, are searching for ways to preserve humanity, meaning, and compassionate care within increasingly demanding healthcare systems. By 2025 and 2026, many additional specie training programs has already been established. And from our perspective, this is at least encouraging. because it suggests that spiritual care is gradually moving from a marginal topic towards a more integrative dimension of healthcare practice. At the center of all these findings lies a profound insight. Spiritual needs are expressions of human belonging or longing for meaning, connection, dignity, peace, and being seen. Some of these needs can be delivered, and others remain permanently human. And perhaps spiritual needs should be understood as vital signs of a person. It's not a secondary aspect of care. So after all these findings, the practical question becomes, what should we actually do? Some recommendations for the, let's say, final stages. First, healthcare professionals must also care for their own resources. It seems quite naive and simple, but please consider, what are you doing for your own health? Drinking beer, that's good. Second, healthcare institutions need environments in which existential and spiritual concerns can legitimately be addressed. Please remember at your hospital. Is it true? Is it really true? It might be naive. Third, patients should be encouraged to speak openly about these concerns. Yet, we do know, as we noticed, patients are reluctantly to talk about these issues because they are not expecting that they could talk about these issues. And again, when the chaplain is coming, several might say, sorry, I'm not intending to die. And finally, we must remain humble. Spiritual care does not mean solving every existential problem. Sometimes it simply means being present. Tove had said it, listening, acknowledging suffering. Acknowledge suffering. Being there. As Christina Puchalski beautifully stated, spiritual or compassionate care involves serving the whole person, the physical, emotional, social, and spiritual. Such service is inherently a spiritual activity. Addressing spiritual needs should thus not be regarded as an optional extra. It reflects whether healthcare truly recognizes the person behind the diagnosis. We also heard it, the patients are more than all the diagnosis. A person with history, values, fears, hopes, relationships, and meaning. Spiritual care therefore represents a core dimension of person-centered healthcare. Not because every professional must become a spiritual expert, but because every patient deserves to be treated as a whole human being. And perhaps is ultimately the ethical foundation of spiritual care. Before closing, I would like to return to a central insight. Of course, patients are asking, can you treat my disease? But very often they're also asking, do you see me? Do I still matter? Spiritual care is ultimately not about providing all these answers. It's about remaining present when these existential questions arise. So let me conclude with 4 brief take-home messages. First, existential and spiritual needs are integral dimension of life and therefore integrative dimension of healthcare itself. It requires awareness. Second, when we acknowledge these needs, patients feel recognized as persons with dignity, individuality, relationships, hopes, and fears. It's a matter of human value and recognition. Third, spiritual care develops most sustainably when interprofessional teams learn, reflect, and work together. Yes, spiritual care remains team spirit, which was very difficult to change. It's a process. And finally, compassionate care requires time. Yes, staffing and organizational support. Because even highly committed healthcare professionals are at risk of emotional exhaustion or burnout when working continuously under pressure. In this sense, spiritual care is also about prevention, not only for patients, but also for healthcare professionals themselves. It's about prevention. Thanks a lot.